Good morning, everyone, and welcome. My name is Meredith Shanda, and I am the COO of the MAVEN Project. Thank you all for joining us today, and for our friends at the Community Health Center of Cape Cod for hosting today's session with Dr. Robert Lohr. A little bit about Dr. Robert Lohr. He was born and raised in Columbus, Nebraska. He received his BA and MD degrees from Northwestern University in Chicago and completed his residency in internal medicine at the Hennepin County Medical Center in Minneapolis, Minnesota. He practiced general internal medicine at the Mayo Clinic in Minnesota since 1993, and in recent years primarily operated in perioperative medicine. He staffed the Mayo Pre-operative Evaluation Clinic and the Internal Medicine Consult Service as well, which focused on perioperative medicine. And Dr. Lohr was also a speaker for several years at the Mayo Perioperative Medicine Update. And with that, Dr. Lohr, I will turn it over to you.
All right. Thank you very much, Meredith. And good morning, everybody. Nice to be with you again. As I told Meredith, it's been raining here quite heavily, and we're in a flood watch and the thunderstorm watch. So hopefully there'll be no lightning or thunder during the next hour or so. I have no disclosures to make, and as Meredith reviewed with you, this has an hour of credit available should you choose to do that. Our objectives today are to, again, understand the basics of a complete pre-op exam, and we actually went through a lot of that 2 weeks ago, so we'll not repeat it. There are a couple of duplicate slides in this deck, but we're going to skim over those very, very quickly today. We want you to know from a cardiac standpoint when to order testing, when it's needed, when it's not, and what to do. We want you to be familiar with and apply the accepted cardiac risk evaluation tools, and we're going to go over 3 of those today and demonstrate how they work. And these are the 3 that are, I think, the most widely used. And lastly, to become familiar with the current ACC/AHA guidelines for cardiac evaluation before non-cardiac surgery. I want to pause here because the word current in that bullet point is the key word. These guidelines were developed in 2014. They are 10 years old, and there is a new set, I'm told, in press. They're always published in circulation, and as of today's issue, they have not been published. So we're going to go with the older guidelines. However, you'll see as I go through this, there are numerous places where I think changes will occur, and we'll try and point out how that's going to work and how the guidelines will be potentially updated. You heard that wonderful introduction, and I won't go through all that again. I just do want to say, though, that again, I'm not a cardiologist and I'm not an anesthesiologist. We talked about this a couple of weeks ago, and I'm not going to review it, but I do want to remind you that you're not clearing patients for surgery. You're doing a consultation. Develop recommendations and provide them to the audience, which is anesthesiology, surgery, and the patient. And last time, one of you said or asked about a template for doing a pre-op exam, and I think I went back to this slide, and I think this is as close as you'll get to a template. And I'm not, again, going to go through this in detail again, since we just did it. But these are the first set of bullets are the areas that you need to be thinking about and addressing if need be. Not every patient has heart or lung problems and so forth. Not every patient is diabetic, but if they are, you need to address that. In addition, for every patient, need to ask about their anesthetic history, if they've had bleeding or clotting problems, including a family history of bleeding or clotting problems, their alcohol use, tobacco use, steroid use, other drugs, chronic pain medication, and sleep apnea. Those are the things that need to be covered. So this is as close to a template as I think you'll get. Now, let's start with a case. This is a 76-year-old male who's scheduled for an elective total knee arthroplasty, TKA. He has a history of coronary artery disease, which has been treated medically. So he does not have stents. He has not had a bypass. He is not able to perform 4 METs of physical activity. And as we'll talk about in some detail, that's the level we're shooting for good functional capacity. But it's mainly due to his knee pain, not so much his cardiac symptoms. In addition, he does water aerobics without limitation. So the water aerobics sort of offload the knee, so it doesn't bother him so much. but he's not limited from a heart standpoint. And as long as these are not the water aerobics designed for patients with severe rheumatoid arthritis, which are quite, they're not very vigorous. If they're regular water aerobics, he is doing 4 mets. So we're pretty confident about his functional capacity. He takes metoprolol, aspirin, atorvastatin, and lisinopril, an appropriate group of drugs at a reasonable dose for his underlying problems. His exam is quite innocent. He has a normal pulse at 62, which is regular, normal blood pressure, no neck vein distension, clear lungs, a soft, rather innocent sounding murmur, and otherwise a normal exam. So what would you advise this patient have preoperatively before his knee replacement? Cardiogram, a chest x-ray, and electrolytes, a dobutamine stress echo with a cardiology consultation to follow, an ECG, electrolytes, continuing his medicines, except for the lisinopril during the perioperative period, a coronary angiogram, the cardiogram lights, the medicines, and a dobutamine stress echo pre-op to decide if you want to do anything further. Now we're going to talk about how we get to the correct answer, which I'll give you in just a second here. Most commonly, people will say, well, number 2, he has this underlying heart problems and we need to assess him. But indeed, the best answer is the cardiogram, the electrolytes, and continuing the medicines. Because his functional capacity is good, he doesn't really need to have any kind of stress testing done. Now, if there had been a change in his clinical status or we weren't confident of his functional capacity, we would probably have to do one or do some sort of stress test. If his ECG, we have one on record that's 6 months, 3 months, 6 months old, but he's clinically stable, you could use that one. You wouldn't even have to repeat that. Going to choice number 1, if you recall from our discussion a couple of weeks ago, he does not need a chest x-ray. He has no pulmonary symptoms and nothing on his exam to drive that. So the best answer really would be just the ECG, the lights, continuing his meds, and we're holding the lisinopril because of the potential for a blood pressure drop when he goes under anesthesia. So how did we come up with this? We're going to walk you through the current ACC-AHA guideline, which, as I said, was 2014. I'm not going to show you a slide of the entire algorithm because it's a ridiculously complicated slide. So we're just going to break it down and go through it step by step. So the first question that you should ask or you should wonder about is the surgery that I'm being asked to see this patient for, is it an emergency? Now, in your office setting, that's rarely going to be the case, although it could be. If you were working in an emergency room, certainly it could be, or if you were working in an inpatient setting, it could be. Now, if it's truly an emergency, you don't do anything. You say, fine, well, yeah, the patient should go to the OR and get whatever it is repaired, and we'll have to try and pick up the pieces after the fact. If it's not an emergency, then you do have to proceed with some further steps. Well, let's define urgency, emergency, and also cardiac risk. So an emergency is a life or limb threatened if the patient is not in the emergency, not in the OR rather, in 6 hours. So this would be a ruptured aortic aneurysm, an ischemic limb that is really not going to last 6 hours without revascularization. Those are the sorts of things that you have to take the patient immediately to the OR, and you don't delay it to do any evaluation. An urgent operation is when you need to get the patient into the OR between 6 and 24 hours. And you may run into this in the office. Certainly we do a lot in the hospital. I think the best example of this is actually a hip fracture. And you're saying, well, why does that have to go so quickly? Well, hip fractures generally occur in elderly patients. And there's a great deal of literature that documents how their morbidity and mortality increases significantly if the surgical repair of the fracture, whether it's pinning or joint replacement, if that isn't done within about 24 to 36 hours. They have more delirium, they have more pain control issues, they have more infection and wound healing issues. They have more blood clotting and pulmonary emboli, and they have more death. So this is considered an urgent operation. Time sensitive would be something that you could delay a matter of weeks, 1 to 6 weeks. I think a good example of this would be a new diagnosis of a malignancy, a renal cell cancer, colon cancer, something that needs to be operated on, but it doesn't have to be tomorrow. An elective is exactly that. It doesn't have to be done at all. This is a choice of the patient and the surgeon, and it can be delayed pretty much indefinitely. Now, risk is considered low if cardiac risk we're talking about here, if it is less than 1%. So it's a fairly high bar. Major risk of major adverse cardiac events, or MI and death, which is abbreviated as MACE. MACE is one of the things you're going to hear about here quite a bit today. The other is MINS, myocardial injury and non-cardiac surgery. If the patient has a risk of less than 1% of MACE, they are considered low risk. If it's 1% or more, they are considered high risk. Okay, next step. It's not an emergency. The next thing is, do you have any active cardiac conditions? And I call these the showstoppers, meaning that if the patient has any of these, you need to stop the show. The train cannot go forward. And it means you need to call the surgeon, not text them, not email them, but call them. And I realize they're in the OR and so forth. So you may have to leave a message, but indicate, there's a problem with this patient from a cardiac standpoint. We can't go forward with the surgery. Please call me back as soon as you can. So what are the showstoppers? Well, they're pretty obvious when you think about it. Unstable coronary syndromes, unstable angina, severe angina, particularly at a low level of activity. And MI within 30 days. Now I have an asterisk here, and we're going to come back to that, but the current guideline says 30 days. That may be something, I think will be something that will change. Decompensated heart failure. So New York Heart Association class 4 or worsening or new heart failure. Significant arrhythmias, high-grade AV block, Mobitz 2, symptomatic ventricular arrhythmias, and SVT with a rate over 100 at rest, or symptomatic bradycardia. Now, the most common thing you're going to encounter here is the SVT, and it's AFib with a rapid ventricular response. And many, many patients are in AFib, as you know. It is preferred that the resting pulse be under 100 from the standpoint of surgery. Now, I know the rate guidelines have gotten a little bit more loose over the last few years, and sometimes we allow people to have a pulse of 100 or 110 at rest if they're tolerating it well. But from a surgical standpoint, we want to try to have it under 100. And then lastly, severe valvular disease. And the two things that you're going to potentially encounter that would, again, stop the surgery would be severe aortic stenosis with or without symptoms, or severe mitral stenosis with symptoms. Mitral stenosis is vanishingly rare in the developed world. It is a result of rheumatic fever. And as you know, people who have strep throat in the developing world get penicillin and they don't get rheumatic fever, so they don't get mitral stenosis. In the developing world, you will see mitral stenosis. I had the opportunity to make several trips to Haiti a number of years ago, and I saw a lot of mitral stenosis and decompensated heart failure as a result of it. So it's out there, but not something you're going to necessarily see in the United States. You will, however, see aortic stenosis. And you need to be able to determine on the basis of your exam, unless you have prior echocardiographic information, if you think this is severe or not. Now, if the patient has symptoms and they have a typical aortic stenosis murmur, if they have symptoms, it's usually severe. The symptoms kind of trump most everything else. And they are angina, syncope, and dyspnea with exertion. But the patient may be asymptomatic, and so you need to know how to examine the patient. And there are two things that you need to look for. First is what's called pulsus, tardus, and parvus. And we're talking about the carotid pulse. And tardus means that it's late, and parvus means that it's attenuated. So you listen to the heart and simultaneously feel the carotid pulse. Now, you're used to having a carotid upstroke in a normal patient right after S1 or right coincident with S1, a nice sharp beat, and then it goes away. And that's normal. In aortic and severe aortic stenosis, the carotid upstroke is not right after S1. It's delayed. It's well into systole. And it doesn't just go up and down. It kind of goes up and fade. So it's late and it's attenuated. The murmur itself is late peaking. In other words, it's not early. It's a crescendo decrescendo murmur. It doesn't peak early in systole, but rather late, almost to S2, and it kind of fades into S2. So it's a late peaking murmur. Pardon me. If you have those sorts of findings and or symptoms, then you need to evaluate this patient further, as we'll talk about. Now, I mentioned the delaying, how long to delay after acute coronary syndrome or a stroke. This was a study that came out just last fall, and that's why I think there may be some changes in the updated guidelines. Big study, they looked at 30-day post-op outcomes, 30-day post-op mortality as the primary outcome, and 60, 90, and 365-day post-op mortality as secondary outcomes. It was done in Britain, and they had a huge number of patients. Among the patients with a previous event, so people that had some coronary event, post-op mortality was increased until there was a plateau of about almost a year, 11.3 months for the primary endpoint and 14.2 months for the secondary endpoints. So what this tells you is that the 30-day delay after a major cardiac event or a stroke may be too soon. There actually has been, in the neurologic literature, a suggestion that this is the case too, that you need to wait a matter of months or even a year after a stroke. So you should at least consider delaying up to a year. Now, the reason for doing the surgery may make that impossible to do. Again, if somebody has a new malignancy and they need to have a resection, you can't wait a year. But if there is an opportunity to wait longer, in this case, is probably better. Well, getting back to valvular heart disease, if you suspect moderate or greater degrees of valvular stenosis or regurgitation, or there's a change in their clinical status, then you need to get an echocardiogram to verify what your clinical suspicion is. So that may delay things a little bit, but often you can get that fairly quickly. If the patient meets the standard indications for valvular intervention, so this would be the patient you think has severe AS, they may or may not have symptoms, but they have the murmur that seems characteristic, and they have the echocardiographic findings of severe AS, which is a gradient across the valve of 40 millimeters or more, or a valve area of less than 1 centimeter. Then the guidelines, and this won't change, will tell you that you need to have the valve repaired or replaced before you proceed with the initial elective surgery. So if you're seeing somebody for the knee replacement, as our patient was getting, and they have severe aortic stenosis verified by echo, they need to be seen by cardiology and ultimately a cardiac surgeon. Sometimes you don't have time to do that. So on the last bullet, this refers to the patient who rolls into the hospital. They need an operation. I think, again, a hip fracture is a good example of this. You determine they have severe aortic stenosis, but you clearly are not going to be able to intervene with the valve, in the next few hours. So the patient has to go to the OR, but this is the situation where you need to try and make sure that you clearly indicated in your note that the patient has severe AS and is going to potentially have problems in the OR and after the surgery, and get that message particularly to anesthesia. Ideally, which is not an easy thing to do, you would talk to the anesthesiologist who's going to do this patient that day. I can tell you that the only person that knows who that is the nurse manager in the pre-op area. So if you can track that nurse down, they can get you to the right anesthesiologist. Okay. We've determined we have no active conditions, no showstoppers. So if there are no active conditions and we think that the MACE is less than 1% and it's low risk surgery, you're done. You can send the patient to the OR. If it's not low risk, then you may have to do some more things. So what is low risk? Endoscopic procedures, derm, cataract surgery, breast surgery, ambulatory surgery, and dental procedures. Intermediate risk would be intraperitoneal and intrathoracic. CEA is carotid endarterectomy, head and neck surgery, orthopedic surgery, and prostate and urologic surgery. So this intermediate risk group is what you, I'm sure, often see, as well as some of the low risk patients too. I'll point out when we talk about one of the risk stratifiers that although the guideline lists intraperitoneal and intrathoracic surgery as intermediate risk, at least one of the risk stratification tools lists those as high risk. Generally, though, high-risk surgery is vascular in nature. Peripheral vascular, especially if it's suprainguinal, pulmonary and liver transplant surgery, and pneumonectomy. Now, these sorts of patients are almost certainly going to be followed by cardiology or pulmonary medicine, maybe GI. And if you're asked to do the pre-op evaluation for somebody for, we'll just say a lung resection or a pneumonectomy, it may be reasonable to get back to the person requesting the pre-op exam and say, you know, this patient's followed by Dr. So-and-so, the pulmonary doctor, and that probably is the person who should do the pre-op evaluation rather than a primary care provider. And I think that's also the case with the transplants and if it's major vascular surgery. All right, let's get to functional capacity. We want everybody to be able to do 4 METs. So climb a flight of stairs, walk up a hill for a block or 2. 10 METs, which is as high as the thing goes, is, you know, strenuous sports, swimming, singles tennis, basketball, that sort of thing. If you can do at least 4 METs, generally speaking, your functional capacity would allow you to proceed to the OR. If you can't do 4 METs, then you may have to evaluate the patient further to determine if, you know, what their functional capacity actually is. Now, historically and typically, we've just asked patients, well, can you climb a flight of stairs? Can you do this or that? And, you know, you get some information and you kind of get patient gets around and you make a decision, okay, they can do 4 METs or they can't do 4 METs. But it is nice to be able to evaluate this in a little bit more objective fashion. And this is something that I suggest that you use, the Duke Activity Status Index, or DASI, developed a long time ago, but it has been shown to be more accurate than just the unstructured, you know, can you climb a flight of stairs questions. A score of over 35 suggests a decreased risk, cardiac risk at 30 days of death or MI. Now, this is the DASI. I'm not going to go through all these questions, but it's fairly straightforward. This is the sort of thing that to speed up your day, it would be reasonable to have some copies of it, or maybe a laminated copy or something like that, that your clinical assistant or nurse or whomever might be rooming the patient can actually go through with the patient and tally up the score, and you'll have that information when you walk in the room. Alternatively, it can sometimes be embedded into an electronic record, but it's a very useful tool. I would suggest using it. Okay, so the next step, we aren't sure about the functional capacity, and there may be clinical risk factors. What are the risk factors? Okay, a history of heart disease, decompensated or prior heart failure, stroke or TIA, diabetes, and renal insufficiency. These are all the things that increase your risk of cardiac events, that push your MACE over 1%. And it sort of makes sense. You know, if you've had heart problems, you may have more heart failure and so forth. And stroke, diabetes, we know, is a marker for heart issues and vascular problems, and renal insufficiency is as well. So these are things that we know can cause increased risk. Now we're going to talk a little bit about how we assess that risk with three different tools. The one that is, I think, used most widely and is the oldest is the Revised Cardiac Risk Index, or the RCRI. And I'm sure most of you are familiar with this. It does predict major cardiac events, including MIs, pulmonary edema, VFib, cardiac arrest, and complete heart block. Been validated, been around. You can see it was developed in 1999, so it's been around a long time. The things that get you points on the RCRI tool are high-risk procedures. Now, again, in this case, they list intraperitoneal and intrathoracic as high risk, as well as vascular procedures. A history of ischemic heart disease, a history of heart failure, stroke or TIA, diabetes treated with insulin, and a pre-op creatinine of over 2, which generally suggests a GFR of under 30 or 30-ish. Pardon me. So these are the things that, if you have, any of these, they each give you 1 point on the RCRI. And this is how it works out. No points, you have a 0.4 risk of MACE, 1 point, 0.9, and everything above that is well over 1%. So 0 or 1 would be considered low risk in terms of MACE, and over 1 would be higher risk. Now, this again was developed a long time ago, and it was developed before some of the tools that we now have to diagnose ischemia and so forth were available. We did not have BNPs, we didn't have troponins. So there has been worry that patients in this low category, 0 and 1 point, that we may be missing some patients. And indeed, that I think is the case. And this is another situation where I think we're going to see changes in the new guidelines. A couple of things here. The Cochrane database review a couple of years ago concluded that the RCRI improved when the BNP or troponin or a combination were added. Canadian Journal of Cardiology, same year, they did a secondary analysis of, again, a large number of patients over 45 who had an inpatient cardiac, rather non-cardiac surgery. 35% had a major adverse cardiac event, including MINS. This is the myocardial injury with non-cardiac surgery. And they had an RCRI score of 0. So these events would not have been detective without a high sensitivity troponin evaluation. So the lesson here is that if you're going to use the RCRI and the score is low, you should probably use one of the newer risk calculators, and we're going to go through both of these briefly. So if the score is high, you don't have to do that, because the sensitivity with the RCRI is much better if the score is higher. But at the low, 0 or 1, it isn't so good. Okay. The next indicator, the calculator we're going to use and go through is called the NISQIP Surgical Risk Calculator. And some of you may be familiar with this as well. This was developed by the American College of Surgeons, and NISQIP is the National Surgical Quality Improvement Project database. So surgeons from all over the country feed data into this database, and they've developed this risk calculator. And we're going to try and walk you through it here. So you'll have to bear with me a minute or two. First, I have to tell them I'm not a robot, and they want to know about crosswalks. So we'll do that. And I guess that's not. Okay. You have to do that. Okay. Now, you do have to load a fair amount of information into this tool. It can be done fairly quickly, but you do have to put a fair amount in. But as you'll see, you get a lot of information out. And we're going to, make up a patient and create a patient, pretty sick patient who's going to have a major procedure. So we're going to say that this is a lady who has got a presumed disseminated ovarian cancer with widely spread mets in the peritoneum, and she's going to go in for a debulking procedure, so a big operation. and there are no other good options for her. And we're going to make her a little more complicated than this. So she is going to be old. Her functional status is partially dependent. It is not an emergency, it's some urgency. They ask you to fill in the ASA class. This is the American Society of Anesthesiology. And this is a classification system that anesthesiology has used since the 1950s. And it does help them set up and predict who they're going to have more or less problems with. But it's very straightforward. Class 1 is a healthy patient. Class 2 has mild systemic disease, so asthma that's well controlled, hypertension that's well controlled. Severe systemic disease would be, any of those, but not so well controlled, or a diabetic who is not well controlled. Severe systemic disease, constant threat to life, maybe severe COPD, oxygen dependent, severe angina, class 3 or 4 heart failure, that sort of thing. And then moribund, not expected to survive surgery. There is a class 6 for organ procurement as well. Now, we're going to say that our patient has severe systemic disease. She has not used steroids. She does have ascites. It's a malignant ascites due to her ovarian cancer. She's not been septic. She's not ventilator dependent. She does have disseminated cancer. We'll say that she is diabetic and she's on insulin. She has hypertension. She has not had heart failure. Well, I'm going to say she does have some heart failure. And a little dyspnea with moderate exertion. No COPD, not dialysis. We'll say she has some AKI that's related to the ovarian cancer and maybe some obstruction. And we're going to make her fairly heavy. Okay, so we've put all this stuff in, and I'm still not a robot. This is what you get. This can be printed off, but on the left are the outcomes: serious complication, any complication, pneumonia, cardiac, surgical site infection, UTI, DVT, renal failure. They didn't do because it's inapplicable to patients with pre-op renal failure or dialysis. And we said she had AKI. So she already had some problems. Readmission, return to the OR, death, discharge to a nursing home, and sepsis. On the right, we have the risk of this patient and then the average risk. So she's above average on pretty much everything. But it gives you a very broad picture of what's going on or what may go on with this patient and can help you formulate some specific recommendations. It also, patients who are frail may ask you, am I going to survive this operation? And I wouldn't necessarily say, well, you have a almost 60% chance of not surviving it. You can couch that in terms that are perhaps more understandable by the patient, and that you do have a high risk of not surviving, but not doing the operation would be a potentially worse situation. But this is a very, very useful tool and can be used really pretty much for any type of operation. Okay. The last one we're going to go through is called the AUB has two. AUB is American University of Beirut, which is where this was developed. So HAS refers to heart disease, age or anemia, and surgery, and each of those letters has two components. So heart disease, history of heart disease or symptoms, and each of those gets 1 point. Age over 75 and anemia, hemoglobin less than 12 gets 1 point, and then emergency or vascular surgery. So you have a maximum of 6 points here. So score of 0, low risk, anything above that is higher risk. So this again is only cardiovascular risk. It doesn't address all the things that the NSQIP did, but it does address the cardiovascular risk, and I think is more sensitive than the RCRI. So again, if you're using the RCRI and the score is 0 or 1, use either this or the NSQIP in addition. Okay, so the MACE is greater than 1 and we can't assess their functional capacity. So we need to consider further testing. We need to do that if the results will really impact what we do. Will the patient agree, or is the patient a candidate for cardiac revascularization if the further testing is abnormal? Would they consider angiography? It is, however, not recommended that routine coronary revascularization before cardiac surgery be done only to reduce perioperative events. And the reason is that when this has been studied, it really hasn't necessarily reduced cardiac events. And this is the reason why some of the more recent guidelines, and we'll talk about this, the Canadian guidelines specifically, don't recommend stress testing of any kind. Well, if you're going to do it, however, what should you do? We do a dobutamine stress echo. There are other ways to approach this. Often the patients are not ambulatory, so you can't just put them on a treadmill. You'll have to do some sort of a chemical test, but it can be a radionuclear test or something like the dobutamine. We like the dobutamine because it really gives you a very accurate and graphic picture of what happens to the patient's heart as the pulse rate goes up. So the dobutamine is infused, the pulse rate goes up, and you can actually see the ventricular wall motion abnormalities developing at certain heart rates. So if that happens at a rate of, we'll say 130, the anesthesia knows they got to keep the pulse under 130 if we're going to get the patient through from a cardiac standpoint. So it really does help risk stratify and helps from a practical standpoint as well. Now, I mentioned the Canadian guidelines are different. These were developed in 2017. They do not recommend any stress testing for patients over 65 or those 45 to 64 with a history of all the things that we talked about that are risk factors: coronary artery disease, stroke. They add peripheral arterial disease, heart failure, severe pulmonary hypertension, that's PH, or they have an RCRI score of greater or equal to 1, then those patients should have a BNP. And if that is elevated, then you don't stress test them, you monitor them very carefully post-op with ECGs and troponin. And they suggest co-management with a medical specialist post-op as well. Usually that ends up being a cardiologist. So I think the new American guidelines, I don't know that they'll say exactly this, of course. I don't know what they'll say, but I think that they will take this into account. And I think there'll be less emphasis on doing stress testing and maybe more emphasis on something like this and doing a BNP or maybe even a troponin pre-op and see where the patient risk stratifies from that. So with the current guidelines, what do you do? So you've got a patient that you're wondering, do I do some testing further or not? You know, you can do a BNP. That might help you if that was elevated. In the United States, you probably do the testing. In Canada, you would not. I think the easiest way to approach this is to simply take the surgical question out of the equation and say, you know, what if I was seeing this patient just for a general exam? They came in and they gave me this history of some dyspnea on exertion and a little chest tightness with some exertion. Would I stress test this patient? And if the answer is yes in that setting, it should be yes in the pre-op setting as well. All right. Okay. A word about beta blockers. There were some very old trials that suggested that everybody should go on a beta blocker pre-op, specifically atenolol, which we don't use too much anymore, and that patients did better if they were on a beta blocker. Well, that study was discredited. It turns out there was some data manipulation and you know, it just wasn't a credible study. Then shortly after that, or a few years after that, the POISE trial was done. And this suggested that beta blockers were harmful if given preoperatively. But the study was criticized, I think justifiably, because of their protocol of how they did this. They took patients who were beta blocker naive, and they gave them a massive dose of metoprolol, 200 milligrams pre-op, and then another dose 6 hours later. And not surprisingly, they had a fair amount of hypotension, some bradycardia, and they had a higher rate of strokes and MIs. There's also been some more recent retrospective studies that in general suggest the beta blockers may be harmful. So what do you do with the beta blockers? Well, if someone is on a beta blocker, continue it. You don't want to try and taper it or anything like that, especially if they're on it for a legitimate reason. If the patient is not on a beta blocker and they really are at high risk and have 3 or more RCRI risk factors, so they're really at high risk and they ought to be on a beta blocker, you could consider starting before surgery. If the patient has some other long-term indication, non-cardiac, to be on a beta blocker, then you shouldn't start it. That it doesn't mitigate anything, and it's of uncertain value in the preoperative setting. Importantly, and this is the most important thing on this slide, if you do start, you should not do it right before the surgery. It should be days to a week or more before the surgery, and you should see the patient back before the surgery and make sure that they're hemodynamically stable, their blood pressure and their pulse are good, they're tolerating the beta blocker okay. You should not start the day of surgery. That can get you into trouble, get the patient into trouble. What about hypertension? Well, the bar is not very high here. 180 over 110 is sort of the cutoff. Anything less than that is fine. So you can generally proceed unless there are symptoms. Now, if the patient has a high blood pressure and they're having a TIA, that's a different story. But if it's not a hypertensive emergency, then you can proceed. Anesthesia is much happier with a high blood pressure than a low. We talked a couple of weeks ago about the ACEs and ARBs and how you might not want to give that the morning of surgery, particularly if they start out with a well-controlled blood pressure because of the potential for the systolic drop. Statins are good. They're pretty harmless. There's actually some evidence in vascular surgery that they are helpful post-op if the patient's not on one. Most of these patients are on statins, but nevertheless, you may have a situation where they're not, and no harm in starting one. Alpha-2 agonists are not recommended for anything in terms of risk abatement. Antiplatelet drugs. Now, the 2014 guidelines are described in these bullets, but the AHA 2 years later in 2016 revised them. So this is the current recommendations, and I'll walk you through this. Patients are treated with a stent, and they're now going to undergo elective non-cardiac surgery. So if a bare metal stent is placed, you should wait at least 30 days before operating. If it's over 30 days, you can proceed. Now, bare metal stents are very rarely placed these days because the effectiveness of the drug-eluting stents is better. But there are situations where a bare metal stent would be placed, and that's usually the patient who comes in and, again, they have a new kidney cancer. They need to have it resected. They just had, but they have this cardiac problem. So they're stented, but we don't want to wait as long as we have to with the drug-eluting stents, so they put a bare metal stent in and you can operate sooner. For the drug-eluting stents, which is most of them, 3 months is the minimum. 3 to 6 months, proceed maybe. And if it's over 6 months, you can generally proceed. Now, this is the time that you consider stopping the dual active platelet regimen, and patients historically have just gone on aspirin, and you can continue the aspirin with most operations. Most surgeons will operate on it. Again, as we talked about a few weeks ago, the neurosurgical procedures may be the exception to that. There's evidence now that either clopidogrel or ticagrelor are better as single agents than aspirin. So you may encounter patients who are on one of those, and they need to be switched to the aspirin for the perioperative period because the surgeons are not crazy about operating with those 2 drugs. Okay, what about surveillance? The American guidelines say troponin and ECG should be done post-op if there are symptoms. Post-op screening in the absence of symptoms is of uncertain value, and routine screening is not useful. But we just saw that the Canadian guidelines differ, and they're saying if the BNP was elevated pre-op, then you should do routine routine ECGs and troponins. But again, that's a variation in the guidelines, and we'll have to see what the new American ones say. We talked about COVID a couple of weeks ago, and I'm not going to go through this. Just remember, 7 weeks is kind of the magic. 7 weeks and no symptoms are kind of the magic things. And with the caveat that this more recent study suggested that if the patient's asymptomatic and in the era of wide availability of vaccinations, you may not have to wait as long as that. We talked about OSA and screening. We'll go through that again. And the medicines, again, I'm not going to review this slide again with you, except to remind you about the SGLT2 inhibitors to be held a few days ahead of time because of the risk of normal glycemic ketoacidosis. And the GLP-1 inhibitors held either the day of surgery or the week if it's injected, because of the concern about aspiration, because of delayed gastric emptying, with the caveat that there was a recent study suggesting that in emergency surgery where these drugs were not held, there was not an increased incidence of aspiration. So I personally would still hold them if I can. If you can't, there's probably not a huge risk. And I believe that is it. So I will be happy to answer questions. I'm going to stop the sharing here. And are there questions, I hope?
Yes, Dr. Lohr, that was phenomenal. I really appreciated the tool you shared as well. I had not seen that before. It was really interesting. And we already do have one question in the chat, so I will get into that shortly. But just a reminder to everyone on the call, if you have questions, feel free to either use the raise your hand feature, which is on the bottom of the toolbar if you want to ask your question orally and speak with Dr. Lohr directly, or just type it into the Q&A or the chat. And our first question, Dr. Lohr, it's a twofer. So the first is, for a low-risk surgery like cataract surgery, would you still hold the ACE or the ARB? And the follow-up question is, for patients on high doses of ACE and ARB, do you ever half the dose?
Okay. I think, first of all, cataracts are done with it's about a 20-minute procedure, and it's a local anesthetic, so it's not a general anesthetic. So unless the patient, when you see them for a pre-op eval, and I'll reiterate that we don't even do pre-op evals for cataracts anymore here, with very, very rare exception. But if you are doing one, their blood pressure is 110, at baseline, you may want to hold it, but you really don't have to because it's not a general anesthetic. As far as having the dose, there's no literature on that. And I think, if they're on 40 and you cut it to 20, they still could drop. So I would hold it. The key is to make sure that it's restarted promptly post-op when the blood pressure is stable. Otherwise, the pressure will go up and, you're going to be getting calls about hypertension.
Great, thank you. I believe that's the only question I've seen come in. So I'll give everyone a few minutes if you have questions to type those in the chat. And I'll just review a couple quick housekeeping items while we're doing that. So a reminder to fill out your CME surveys that will pop up after you exit out of the webinar today. Today is May 21st. We are with Dr. Robert Lohr. Make sure to note both of those things in the survey so you get your certificate promptly. If you are watching today's today's webinar with a friend, make sure you message me your email address and information so that I can make sure you get the CME credit and your certificate and slide decks. And other than that, the recording is going to be posted to the MAVEN Project website, typically in about 2 to 3 weeks. And look out for your slide decks coming into the inbox tomorrow from Zoom. So that was all my housekeeping. I don't see any other questions, but I do want to make sure we give people enough time to type them up. Dr. Lohr, any final thoughts or anything you'd like to share to wrap up today's session?
Only that I do see a question here, but I'll give you my wrap up first. If you do have perioperative questions of any kind, there is a perioperative medicine section to, ask for a consult from MAVEN. And there's only 2 people, me and an anesthesiologist named Jim Bird from out in San Francisco, who are in that group. So it'll be one of us who answer the request, and we'll do the consult. So feel free to do that if you do have specific questions.
Yeah, that's really great plug. Thanks, Dr. Lohr. And you were right. We did get one more question about what to do with patients on insulin pumps.
Insulin pumps, that's a good question. Typically, you ask the patient to maintain their basal rate, but not to bolus the morning of surgery. And the anesthesiologist can do one of two things. They can have the pump bolus during the procedure if needed, and they'll monitor their blood sugar, or they can just give them some insulin otherwise. But you don't want the patient to be without insulin, so you maintain their basal rate and have them not do any bolusing, turn the bolus part of the program off until after the surgery.
Great. That was a great question. All right. Last call for questions. I know it's still the morning time and people are getting ready for clinic. Oh, I did see another one come in, Dr. Lohr. So this question is, do you consider the AUB HAS2 equivalent to the NSQIP calculator?
Well, I think from a cardiac standpoint, I do. But the NSQIP has all those other elements to it. So I don't think you can equate them, but strictly from a cardiac standpoint, they're quite similar. And they both work. The AUB HAS2 is quicker, as you could see, but you do get a lot more information from the NSQIP. You have to put more information in, though. So
yeah, it's very thorough. Great question. All right. Don't see any other questions, so I will give everyone another minute and then we will say goodbye to Dr. Lohr for this morning. Thanks again to our friends at the Community Health Center of Cape Cod for requesting and hosting this talk. We really appreciate it and hope you learned as much as I did on today's talk. It was wonderful, Dr. Lohr. So hopefully we'll be seeing you again soon, and I hope everyone has a wonderful day in clinic. We're getting some thank yous already coming in, so I appreciate everyone's time this morning, and we'll hopefully be seeing you soon.
thank you so much. Appreciate your time.
Take care.
Bye-bye.